So good morning to all. Welcome to this webinar on the impact of COVID-19 on the right to mental health in Europe, the fourth in a series of OHCHR webinars. My name is Philip Jaffe, and I will moderate this exchange. I'm a clinical psychologist by training, and what you see on the screen is what you get. I am a professor of children's rights at the University of Geneva and a member of the UN Committee on the Rights of the Child. My job during this webinar is twofold. Firstly, I will try to squeeze as much knowledge and creativity as possible from an amazing group of panelists and discussants. Secondly, I will act as an enforcer to make sure that the program progresses on schedule, and when necessary, I will rudely interrupt speakers. I hope they will forgive me, by the way. Let me briefly remind us all of the context and the objectives. So in addition to economic havoc, COVID-19 has introduced an unforeseen, and I would say monstrous global mental health crisis that has disproportionately affected vulnerable persons and populations. In addition to the public health response, in addition to allocating more resources, introducing effective and innovative programs to counter the impact of this mental health crisis, we also need to adopt a human rights-based approach, one that focuses on enhancing equality and resilience in disadvantaged communities, combating discrimination, and opening access to mental health services to all. For this, we need the involvement and guidance from the human rights community, the human rights treaty bodies, and collaboration with politicians, mental health professionals. But we also need to hear from and work with civil society representing persons whose mental health is affected. So quite a program that we are proposing this morning. And at this point, before introducing the panelists and sharing with all the viewers the rules of this, the housekeeping, if you will, of this webinar, I would like to give the floor to Mr. Antti Kokeakivi for some additional opening remarks. Antti is a jurist, a journalist, and a human rights specialist, and he is currently the chief of the Anti-Torture Capacity Building, Coordination and Fund section in the Human Rights Treaties branch at OHCHR. So Antti, please, you have the floor.
Thank you very much, Philip, and greetings to everybody. It's indeed a major pleasure and honor for me to co-open this webinar on the impact of COVID-19 on the right to mental health in Europe. And as Philip mentioned, this is the fourth in a series of regional webinars. The Human Rights Office, together with treaty bodies, are organizing on this critical topic. And these exchanges, of course, reflect our shared commitment to highlight this critical issue and to advance human rights-based policies in this area. And as you all know, the right to the highest attainable standard of health, including physical and mental health, is guaranteed in international human rights law. And this covers availability, accessibility, and affordability of mental health services. And of course, in accordance with principles of equality and non-discrimination. And as we together work to ensure universal health coverage as a priority, we must ensure that it includes effective mental health remedies and services. And yet, as we've all seen, this pandemic continues to expose wide gaps in the full protection of the right to mental health. And our discussions today will no doubt highlight the various ways in which COVID-19 has had an impact on mental health in Europe. We will examine the situation of persons who have been disproportionately impacted, such as persons with disabilities, women, children, older persons, ethnic, religious, and national minorities, LGBTIQ persons, migrants and refugees, as well as those who are particularly affected as a result of their circumstances, such as extreme poverty, loss of employment, lack of access to education or work opportunities, or those in detention. Now in Europe, we have some initial research that shows how heavy the mental health toll has been on various segments of population. This research shows that the virus, coupled with distancing and isolation, economic and social downturns, unemployment, and increase in domestic and other types of violence have all fueled mental distress, anxiety, and fear. And while we do not yet know the full scope of the impact of COVID-19 on people, the WHO notes that around 1/3 of adults and 50% of younger people are reporting various levels of distress. Now, we hope that our exchange today will allow us to gain further insight into the situation in Europe, and we can explore ways to ensure that COVID-19 response and recovery are consistently grounded in human rights. And this requires public policies that are designed in a transparent and participatory manner, with rights holders, including those that are particularly marginalized, at the table. And this requires policies that are formulated on the basis of disaggregated data. And of course, we also must ensure that duty bearers are accountable to rights holders, as ensuring the right to mental health during and post the pandemic period is not only a moral imperative, but a human rights obligation. So I very much look forward to our discussion today and hand this back to our moderator. Thank you.
Thank you very much, Antti, for fleshing out the parameters of this webinar. I will now introduce the first of the 6 panelists, and I will introduce each as we go along and ask them to share their most synthetic thoughts on the issues. If they could stick to 5 minutes, that would be wonderful. And also add that there is a YouTube audience, for those of you in the YouTube audience, if there are any questions, we will try to get them to the panelists and participants, time permitting. Also be aware that the whole event is recorded, so that you can always go back and review or share also with persons who are not able to attend. So let me move to our first panelist, Elgun Safarov. He is the vice chairperson, excuse me, of CEDAW, the Committee on the Elimination of Discrimination Against Women. He's a law professor who has been representing Azerbaijan in the UN and various other organizations. He has been engaged forever, I should say, in the protection of women and children's rights and on issues relating to gender and gender-based violence. Elgun, please, the floor is yours.
Thank you very much, dear Philip. Thank you very much, organizers, for inviting me to participate in such kind of interesting item conferences and webinars. I want to underline during these 5 minutes main points about our work as a CEDAW committee and what we see is the protection and violation of women's rights directly through the human rights protection system. We know that violation of mental health, it's a violation of law. And some cases can go into the criminal law, some cases to the administrative law legislations, and we can create it directly and must be regulated directly through the international conventions to the national legislation acts. During these years, we see that pandemic situation, we see how the going deepest the problems and the cases against women, violence against women and girls, especially in this point, increasing hate speech, increasing discrimination cases, is increasing the gender-based violence cases as it was earlier in uncommon statistic. It was one of each 3 women was victims. At this moment, more than 60% during the pandemic situation, a woman was and girls was victims of the domestic violence, gender-based violence. We see increasing the selection, abortion, selective abortions. We see the increasing such kind of increasing as alcoholism dependence, narcotic drug users between the women and girls, especially not only and especially full community. And it's all common problems which coming direct to this point. And what to do? How can we answer on this point? How international human rights organizations, especially not only the UN, but at the same time Council of Europe, European Union, will answer for such kind of a challenge and for such kind of problems? What will be done afterwards? What we are trying to do, what we are thinking to get the result of this point. I think we must increase the role of we must work through the rule of law and include much more international conventions to the national legislation acts. Unfortunately, when we're giving the reporting process, main states answering us about that they directly including the convention, but they do not implementing the national legislation acts. Especially, for example, in the criminal courts, for example, article about the forcing for the marriage, articles about the prevention of child marriage, article about the obstetric violence directly in the criminal legislation. Unfortunately, we do not see direct implementation through the Council of Europe and decisions of the European Court of Human Rights implementation. States sometimes do not answering on these decisions and do not implementing it the same year. Unfortunately, it's a reality. And when we say about the women rights violations, we must say violation of women rights in reproductive health system, in education, we say in the election procedures, in all possible systems as we see. And mental health, we have included in each articles of the Convention of CEDAW, and in each point what we have done, especially in the domestic violence, Article 5, fighting with the stereotypes, which are very important, and the article about the reproductive health 11 and 12 of the convention. Unfortunately, we do not see the real challenge and answers. And I think the next generation, next possibility, it's a transformation of United Nations and other international organizations for the direct answering for such kind of conflict situations. And we must go direct on this point. I want to only include this point that last one, I know that we have only 5 minutes, that we must do it step by step. And sometimes United Nations, for example, charter, and then other organizations, charters and documents must be renewed, must be going on, and reforming procedures of all international organizations must be continuing in this point, especially protection of human rights, protection of all categories, women, children, fighting with, against all kinds of the violence. Thank you very much.
We don't hear you.
Yes, I'm corrected. Thank you. I was thanking Elgun for bringing us his view on how to improve the implementation of human rights conventions, and I think your points are well taken in terms of the how this crisis has affected mental health of women and other categories. I will now introduce our next speaker, Ms. Elvina Alameza. She is a social, and sorry for my mispronunciation, she is a social scientist by training, but more importantly, if I may say, she's a member of the European Parliament, where she represents the group of Greens European Free Alliance. Elvina is co-chair of the Coalition for Mental Health and Well-Being in the European Parliament, and her experience predates that function. She was the project manager of the Finnish Association for Mental Health. So Elvina, the floor is yours, please.
Thank you so much. It is such a pleasure to join you. And as you know, the topic is very close to my heart. So it's very good that we will be able to discuss this today. I'm a member of European Parliament, as Philip already introduced. And for me, the reason that I have become active in politics is basically mental health. When I was a teenager, we had a school shooting in my school. And I found out that the person who did that did not receive the mental health services that he was seeking. And this is something that was, of course, deeply traumatizing for me. And as well, many of my friends had the issue of not getting mental health services after this event. And that really woke me up, and I understood that the mental health services in Finland are not good enough. even though we talk a lot about welfare state. And now I've been willing to bring this forward also in the European arena. And in Europe, of course, many of my colleagues sometimes say that it's good that you talk about this, but we don't have mental health issues in my country. But this, of course, is not the case. We have them in all countries. And especially now in the COVID-19 pandemic, even if previously 30 to 70% of people with mental health illness would not get help for that, depending on the member states of European Union. Now, I believe the situation has worsened because many of the services have been shut down because of COVID. And of course, there has been an upsurge of the issues as well, because people have had a lot of economic stress and health stress and all of this that you know about, and that already was introduced by the previous speakers. We have solutions, of course. We can solve these issues. And I think we should use this also as a possibility and a chance for us to make those happen. For me, in the European Parliament, I have proposed a new project, pilot project on psychotherapy, and especially digital psychotherapy, because now during this time, it is true that many of the clinics are closed. So the best way for us to give people treatment would actually be to give them in video meetings and this kind of way. And we know that the mental health help, such as short-term psychotherapy, is very effective. Actually, we have proved that it actually decreases depression symptoms by 50% already in four sessions of short-term psychotherapy. So I hope that we will take this chance all over Europe. We already have done so in Finland. I have been making this initiative on these low threshold clinics where you can just walk in and get up 5 to 10 times of psychotherapy treatment. And those have been greatly successful. So I really hope that we can take this situation seriously and also use this as an opportunity to make our mental health services even better. Thank you all for your great work on this topic. Really happy to join you.
Thank you so much, Alvina, for highlighting the opportunities and how to be proactive during this crisis, and also for highlighting some of the innovative technological approaches. Music to my ears, digital and brief psychotherapy by video links and Zoom. I would like to, I'm excited to introduce our next speaker, Ms. Ledia Lazeri. She is regional advisor on mental health at WHO. She is a medical doctor with a specialization in psychiatry and psychotherapy. She has extensive clinical and mental health policy experience well beyond her native Albania. And among her many accomplishments and interests, let me highlight her work on the empowerment of and advocacy for mental health service users and carers. Ledia, may I ask you to take the floor?
Thank you, Philip. Thank you and good morning all. I'm new to the group, and as Philip kindly introduced me, yes, I'm talking to you from Budapest now, where I have just finished my mandate as the WHO representative to Hungary, and I have taken over my duties as the regional advisor for mental health from last week. But as Philip mentioned, my previous life before Hungary was dedicated to mental health service development, policies, workforce, advocacy for users and carers, and so on. When it comes to, and I'm pretty much familiar with everything related to the UN Convention for Rights of Persons with Disabilities, because I worked with that in a number of countries where I have contributed to services. And more. So coming from a WHO perspective, what I would like to introduce is the awareness that is growing among our member states about not only the importance of mental health, and as my esteemed pre-speaker talked, is like we need to use this as as an opportunity actually, but also, so not only the awareness, but also the sense of urgency. And the sense of urgency because the disruption is so huge that people are missing out. And if we look at it from a human rights perspective, every service denied is a human rights, it's a rights denied, it's an entitlement denied. What we have found in WHO is from last year, WHO globally conducted this survey with its member states, and out of 130 member states that responded, 93% of the member states reported these severe disruptions of mental health services. And then if we take into account how poorly resourced, how underfunded, under-resourced mental health is across the world, we can only be alarmed by the fact that disruption of already poorly resourced mental health services means that an increasing number of people are denied of basic mental health care. When it comes to the European region, a very small remark here, the WHO European region goes beyond the European Union. We have 53 member states that capture from Iceland to Kyrgyzstan and from Russia and Finland to Israel and Greece. So it's a very wide region with a very diverse set of resource level, and also adoption of policies and legislations and service designs, etc., are very diverse across the region. However, following the work that our technical advisory group for mental health has been trying to develop in the last few months, we have found out there is an agreement that the mental health services have been massively disrupted in Europe, all across Europe, at all levels, inpatient care, community care, but also primary health care, because there are some, in between our member states, there are some countries where mental health services are provided exclusively by specialized services, psychiatric services, but also there are a lot of countries where primary health care is heavily involved into delivering mental health services. Another very concerning news is to learn that institutionalized patients have been exposed to infections at great rates. And we have seen basically in Europe how the hotspots for infections became institutions both for older people or for people with any disability. And so those becoming hotspot, it's a big concern because those people are exposed to greater rate than their fellow citizens. So what is the need then? When we acknowledge that the need here is to ensure continuity of care, because everybody is entitled to a basic set of mental health services, and ensuring continuity of care is a basic right in that sense. We also have learned during this pandemic that there are new pockets of vulnerability that we didn't think before. For instance, in mental health, what we were looking before were people with mental health conditions and psychosocial disabilities. But the pandemic brought forward some new groups, such as, for instance, healthcare workers, who are not only exposed to infection at high rates, but also are vulnerable to for mental health issues, vulnerable to mental health conditions. So a new pocket of vulnerability, young people and children are also a new pocket of vulnerability that we need to look at. So the next step after acknowledging the disruption, the severe disruption of services, is to very well explore what are the new vulnerabilities. For instance, the first speaker talked about women, talked about migrants, talked about those pockets that were already vulnerable, but that the pandemic and the disruption that it brought has brought the vulnerability to an extreme that we did not know before. So exploring vulnerable groups, exploring new vulnerabilities is a must when we look for addressing the needs, the new needs. In terms of looking at it from human rights, of course, services, establishing continuity of care, re-establishing the service networks is a must for leaving no one behind. We need to be very open-minded in terms of adopting the advancement of technologies. For instance, a lot have been talked about digital technologies in expanding access to mental health care, but we need to be aware that not everywhere and not everybody has similar access to digital technologies. So over-reliance to digital technologies for making up the under-resourced mental health services might mean that those who have less access to digital technologies will be left behind. So we need to be very, very mindful and to tailor every measure that is on the table, to measure them as per the conditions of every population group. Imagine the older people or migrants or people with chronic pre-existing mental health conditions might have less access and less literacy in using digital technologies, and therefore we need to be very mindful when designing services for them. All those, to close my little intervention.
I must
yes,
ask
I'm concluding. Of course, so sorry for this. All those are now being put into the new European framework for mental health action that we are presenting to our member states in the Regional Committee for Europe in September this year, and that will give us legitimacy in WHO to address those identified needs in a systematic and a comprehensive way together with our member states. Thank you very much, and sorry for taking a bit more time. Thank you.
No, I'm sorry I'm being rude to interrupt you, but I'm trying to move things along in all fairness to all participants. Thank you very much, Lydia, and important aspects of how global health, mental health governance can go forward. Next, I would like to, it only gets better, and I would like to introduce Ms. Christine Dupate, a law professor at the University of Latvia. She is a member of the Committee of Social Rights of the Council of Europe, and she has a very long professional experience in the field of human rights, including gender equality, non-discrimination, social security law, and I'm sure I'm leaving out many important elements. Christine, we are eager to hear your intervention. Please.
Yes, thank you very much. So first, I would like to say that this webinar on mental health issues is, of course, very highly appreciated, as it is vital. So, because as we all know, the mental health issues has amounted to critical point, and unfortunately, at least for me, and I think for many others, so we have learned about this problem not from reports or researches, but from our closest environment. So, and yes, I'm representing European Social Rights Committee. So, and I will look on this issue more from the legal perspective. And the good news is that European Social Charter is exactly that legal document, which actually targets almost all rights which are relevant or which are causes for this ill mental health. So, because first of all, European Social Charter provides for the right to the protection of health. Then it also provides specific obligations with regard to some vulnerable groups, like elderly and children and young persons. And then European Social Charter also addresses all socio-economic rights which are relevant to this COVID-19 and related problems, like obligation to establish social insurance, to have social assistance system, then have specific measures for the protection of families and children. Then of course there must be protection against poverty and social exclusion, right to housing, right to work, and right to health and safety at work. So it means that our committee, European Social Rights Committee, is fully legally equipped to request from the states so that they comply with all the obligations stemming from European Social Rights Charter, and of course all obligations related to the right to mental health. So, and but this is legally, this is formally, as we all know, in practice is not so easy. And I would say so that that unfortunately this social rights for many years have been left behind civil and political rights, even though we consider that provision of social rights is a precondition for full enjoyment of civil and political rights. So, and what I see, speaking about mental health issues, so that it is far more easy to solve those causes to ill mental health from socio-economic perspective, because it is just a matter of financial means available. However, regarding those causes to ill mental health caused by lockdown and isolation, so it really requires provision of professional services, and unfortunately, provision of professional services is not only dependent on financial resources, but from human resources, and unfortunately, I'm guessing I'm just referring to experience of my own country. So unfortunately, we may fall short of human resources, of psychologists, psychiatrists, psychotherapists, because establishment of such system requires long-term policy. But speaking about good practices from the member states, unfortunately, the committee does not possess yet information regarding good practices from the member states regarding mental health issues, as we are working. Our monitoring procedure is reporting from the member states, and it takes some time to ask specific questions, and then the states need time to prepare a report. The fact is that our committee adopted a statement on April last year on the right to protection of health in the time of pandemic, and along with this, the committee asked the question regarding measures taken due to COVID-19. So, and we are still awaiting replies, but I would say that those reports already submitted, they provides us information on the measures taken directly related to COVID-19, and they do not provide, unfortunately, specific information relating to problems who have arise due to COVID-19. So
Christine, I have to ask you to conclude.
Yes, and actually, this is what I wanted to say, and I'm here to say that the committee is fully committed to raise a mental health issue and to work with it. Thank you.
Thank you so much. As a moderator, I'm always worried that I will make many enemies for the future. So please don't hold it against me, but against the clock. Thank you, Christine, and thank you also for highlighting that more research has to be done and that human resources are paramount. I am so pleased at this point to get to Ms. Guadalupe Morales Cano, who is the director of the Fundación Mundo Bipolar, and her main interests are raising the voice of people with mental health problems at a political level, to have a meaningful involvement in every aspect related to promoting their rights and developing projects and training peers and professionals and research. And Guadalupe, I recently read in an interview you gave that you carry out peer-to-peer training as well as with mental health professionals to fight stigma and discrimination. And you reported, and I actually am not that surprised, but I think it's important to underscore that very few of your participants had ever heard of CRPD, the Convention on the Rights of Persons with Disabilities. Yes. So your voice today is very important, and please take the floor.
Thank you very much. It's a real pleasure and honor to be here. I'm gonna be as fast as possible, and so maybe I read too fast also. Well, as it was said, Fundación Mundo Bipolar is a non-profit entity in Madrid, Spain. It's the only user-led national organization. Its main objective is to fight for the rights against stigma and discrimination of people with mental health problems or psychosocial disability based on the EU1 CRPD. We've proven the effectiveness of peer-to-peer trainings and having peer experts or peer workers train professionals combined with research activities. Everybody seems to know that what human rights are. However, why is it not so clear when it comes to the human rights perspective in the field of mental health? Why are we considered ill people who do not deserve to have the same rights, that we are objects of care and not holders of rights in the first place? We witness huge inspiring steps by humankind to protect persons in vulnerable situations and guarantee their rights. From the Universal Declarations of Human Rights in 1948 to the very important UN CRPD in 2006. This one is legally binding on states, but national mental health laws have remained far behind. The same is true for Europe, with many good intentions, declarations, and programs throughout the years. This sounds good, but most of them, it seems that they are reinventing the wheel. Only nice words, lost in the dust. In my opinion, they all lack of the meaningful involvement of persons with psychosocial disability. Our voice is not really heard. Are we being instrumentalized with a token role? I hope no. An important exception was the case of our involvement in the CRPD Committee's recommendations to the European Union in 2015. Sadly, mostly have been ignored till now. As soon as there's no specific budget, policy commitment, and constant evaluation of implementation, including, of course, monitoring by users of the activities, services, projects, etc., there's nothing. I'm going to talk a little bit about the pandemic. During this pandemic, our Spanish collective reacted excellently during harsh confinement. We had intense online network. The self-help groups were infinitely necessary and beneficial. After all, we had experience of being locked in the past. This is a kind of joke, but it is true. However, those who had been admitted to psychiatric hospitals suffered greatly. In addition to have lost their freedom, as always happened, they were completely isolated from the outside and weren't allowed to go out or receive visitors. They were unable to communicate for months, except from one call from the outside. They could not use their mobile phones, nor were they provided with a tablet or similar. They lived a double confinement for many, many months. Consider that psychiatric units in my country, Spain, and I'm sure that many other countries in Europe, our psychiatric units are corridors without outdoor space. All psychiatric patients have to wear the same impersonal pajamas. The situation recently has been a lot worse than that of the prisoners. Digitalization has become a matter of utmost importance during this pandemic. Digital devices have marked an impact on mental health, since communication with others is vital. Loneliness is a risk factor. Then we have the digital gap. Telemedicine is a fact, although face-to-face is necessary in mental health. Conclusion. What does building back better mean in mental health? Is it more mini institutions or even new disorders in manuals, as some psychiatrists have suggested? Continued over-reliance on pharmaceutical treatments, or rather a radical shift to taking person's experience seriously, placing us at the center of decision-making, leading to full participation, strengthening community-based support, especially peer support, and stop stigmatizing and discriminating mental health difficulties. There could be an historic change of paradigm. We must stop thinking that there's mainly a health problem. The main problem is lack of rights and, above all, our capacity as citizens. And finally, how can we claim, fight for our rights if we don't even know they exist? Thank you very much.
Well, dear Guadalupe, thank you very much for those words of wisdom, I even want to say, and for highlighting the need to build back, but to take into account lessons learned and to inject more resilience into the system, also through a very basic human rights principle, which is participation. And that's not just a buzzword. It should be taken into account from the users and providers all the way up to policymakers. I would like to introduce Ms. Tina Stavrinaki, who is a member of CERD, the Committee on the Elimination of Racial Discrimination. She is a researcher and teaching assistant in international human rights law and has worked for the National Commission for Human Rights and UNHCR in Greece. And she has also been in the trenches, so to speak, active in the field of supporting victims of hate crimes. Tina, please take the floor. Go ahead.
Thank you, Philip, and many thanks to the organizers for this discussion. As a member of the Committee on the Elimination of Racial Discrimination, I will focus on this intersection of, the pandemic, mental health, and racial discrimination. So, research has shown a long time ago, before the pandemic, that cumulative exposure to racial discrimination is a determinant of chronic social stress that, of course, negatively impacts mental health. So, of course, it's a matter of individual conditions, but in general, it's a very dynamic process involving many components. So, first, the internalization of fear and trauma of racial discrimination, a fear that becomes stronger when the person was subjected to racially motivated violence. And of course, structural inequality in mental health services that lead very often to various forms of vulnerabilities and intersectional discrimination. We know from studies that individuals and groups vulnerable to racial discrimination have received less patient-centered communication in health services. They meet cultural barriers. They have many misdiagnoses. And of course, as you know, they're overrepresented in the justice system than in care services. So the Committee on the Elimination of Racial Discrimination has described in a statement on the pandemic adopted last August, how the COVID-19 influenced the right to non-discrimination and to equality. And the burden on mental health has disproportionately increased for individuals and groups subjected to racial discrimination during the pandemic for several reasons that at the same time are the areas of concern where we need to take measures. First of all, the fear of exposure to the virus due to living conditions in crowded settlements, in remote communities with limited or no access to clean water and sanitation facilities, with limited or no access to healthcare and medication, which of course, as a result, led to higher rates of infection and mortality. The negative impact, it has already been said, the negative impact of the pandemic also on health services for other diseases. So we had, sudden interruptions or changes in the treatment process. And now as we speak, mental health services centers, at regional level, local level, within the communities, are replaced by, vaccination service, which is of course, understandable, and we understand that how difficult it is to, find the right balance. The pandemic so exposes, but also, deepens further structural inequalities. It has a significant disparate socioeconomic impact on groups and minorities subjected to racial discrimination regarding housing, employment, education for children and young persons, as well as economic, security in general. The gender divide, which was also mentioned before, we know that pushed many women, of course, affected even more women, belonging to racial and ethnic minorities, and they pushed them further from the labor market. So we should also keep in mind this increase in stigmatization, labeling, in scapegoating, which resulted in many cases in not only in discriminatory acts, but also even to hate crimes and verbal abuse. And we see during the pandemic that even previously covert discrimination against specific groups now has become overt and extremely violent. And I invite you to see the latest statement adopted by CERD on the rise of racial discrimination against Asians and people of Asian descent. So finally, the burden on mental health was increased due to practices and incidents of racially discriminatory enforcement of these restrictions on human rights related to the pandemic. So we should see the current situation as a complex intersection between the pandemic, mental health inequalities, and racial discriminations and discrimination. And experts, we see that they conceptualize it as, a new epidemic. So coping mechanisms developed through generations and within communities against the fear and trauma of racial discrimination may no longer be as effective as they used to be under these circumstances. However, we have more data and better knowledge now than ever. So research shows that mitigating socioeconomic inequality due to racial discrimination may also mitigate inequalities in mental health. What we need to do is, of course, to continuously improve data collection and statistics on the right to mental health, in line, of course, with obligations related to algorithmic profiling. So for the first intervention, my last point, I just want to share that CERD will start working on a general recommendation on the right to health and racial discrimination. And of course, we have very good reasons to believe that mental health will have a special place in this general recommendation. States must protect against and mitigate the impact of the pandemic on, individuals and groups subject to structural racial discrimination. They have to take into account the gender-related dimensions of racial discrimination in compliance with obligations under international human rights law. Thank you.
You are muted.
Yeah, thank you, Tina. I'm sorry I was muted, and I made a very interesting speech to thank you for your insights and highlighting governmental responsibility and the need for research and other points that you made, which are very important, but also bringing up the issue of how the pandemic is also, and I put in quotes, freed certain segments of the population to let loose in negative ways. which creates also more victims. At this point, this closes the brief presentations of our panelists, and I would like to thank them very much for their interventions, and they may come back at some later point, time permitting. So now I turn to a distinguished group of participants to ask for their reactions and comments. And just to repeat what I already put in the chat, if you would like to take the floor, please put your name in capital letters in the chat. Please keep your remarks short, 2 minutes maximum. As I often say, a basic human right is the ability to practice turn-taking in a conversation. So let's put that into practice and have a conversation that respects everyone. So at this point, I would like to give the floor to Erdogan İskan, who is a member of the Committee Against Torture at the UN. Erdogan, please take the floor.
I hope I'm unmuted. Yes. Thank you, Philip. We have heard valuable inputs from many distinguished experts. My contribution will be from a wider political perspective. I have examined certain surveys about change in emotional and mental health during the last 1 year, which indicate that large percentage of populations, and in some cases, including, for example, Turkey, over half of the population feel more depressed and pessimistic. Why? What might be the fundamental reasons for such worrying situations? First, the virus killing many horrible people in horrible conditions. Second, social distancing, lockdowns, and inconsistent measures cause emotional distress and mental ill health. Third, social deepening, I think I should mention earlier, this lack of reliable information on the evolution of the pandemic magnifies the impact on emotional and mental health. And deepening economic difficulties and lack of responsible, reliable response from governments create a sense of insecurity for the future. What needs to be done? At national level, I believe governments need to implement a human rights-based approach, allocating adequate funds aimed at enhancing the quality of resilience. Non-essential investments must be deferred, and governments also need to provide the public with credible information, and populist practices must be abandoned. At international level, findings and recommendations of the United Nations must be given due consideration, and international collaboration must be enhanced. For the UN treaty bodies, which have been prevented from fully functioning, they have been innovative with a view to addressing the increasing backlog. They have also provided substantial guidance to assist the member states. For as to CAT, the Committee Against Torture, of which I am a member, we have included the topic into our agenda, inviting the states parties to provide information on the steps taken during the pandemic. The potential to develop mental ill health is prevalent. Mental health and psychosocial trauma cannot be fixed easily. Psychosocial support is not luxury, but necessity. This was a brief overview of my intended statement. The full text has been provided to the Secretariat, Philip. I thank you very much.
I thank you very much, dear Erdogan, for those comments and the statement. I would like to pass the floor to Stephen Allen, who is from the Validity Foundation, which is a NGO working on the rights of persons with mental disabilities. Stephen, you have the floor for less than 2 minutes, if you could.
Good morning, and thank you for the invitation to join you today. I will just briefly draw on the findings of the COVID-19 Disability Rights Monitor in this short intervention. This was a rapid global human rights monitoring initiative which Validity and 6 other leading disability rights organizations undertook last year to look at the human rights implications for the pandemic. The final report is available at covid-drm.org. Some key findings were as follows. 1, we were seriously concerned to see that there were discriminatory triage policies reported by many persons with psychosocial disabilities around the world, denying them access to basic, emergency, and general health care, including mental health care. Secondly, in many EU countries, psychiatric hospitals and other residential settings for persons with disabilities were completely locked down, often for many months. People were hermetically sealed off from society, often for much longer periods than national lockdowns were in place. Third, we now know that these settings were indeed the hotbeds of the pandemic. Instead of prioritizing emergency deinstitutionalization, people were instead locked in, and we heard numerous allegations of the virus running rampant in such facilities, leading to disproportionately high levels of deaths. And fourth, we are seriously concerned that, about other human rights violations that took place in such settings, given that there was a complete halt in most countries to any form of independent monitoring. Let me just put 4 brief recommendations to inform this discussion. First, we think it's crucial that persons with disabilities are fully included in response and recovery plans. We cannot any longer accept the premise that this humanitarian crisis should reduce persons with disabilities merely to victims who need aid. We must take a human rights-based approach to the provision of mental health care. Secondly, we express our deep concern about a Council of Europe proposal to rush through a protocol to the Oviedo Convention, which will legalize involuntary detention and treatment of persons with psychosocial disabilities. This is a dangerous proposal. It undermines international law. It is the wrong proposal at the wrong time, and it should be withdrawn. Thirdly, we underline that the right to mental health can only be ensured by ensuring the availability of services in the community, and that these must be provided on the basis of voluntary informed consent. We need to end the institutionalized approach to psychiatric care, promote emergency deinstitutionalization, and ensure everyone has the support in the community that they need. And finally, we call on the European Union and other international bodies providing recovery investments to prevent their funding from going to settings which further segregate and isolate persons with disabilities. In the rush to build back better, we should avoid that these investments go into settings that isolate and segregate persons with psychosocial disabilities from our societies. Thank you.
Thank you very much, Stephen. And even though you went over time, I could not interrupt you because you made some extremely valuable points, and that we should all hear loud and clear. Let me move on to Marine Uldry, who is from the European Disability Forum. Marine, like everyone, please keep your remarks short and sweet.
Yes, good morning, everyone, and thank you very much for this peer-to-peer exchange. So I work for the European Disability Forum. We are an umbrella organization of persons with disability defending their rights in Europe. And I will briefly complement and add to what Stephen Allen just said. So since the beginning of the pandemic, we actually monitored impact on persons with disability thanks to our members that are based in all European countries. And there is really no doubt that the mental health of persons with disabilities has been quite heavily affected. In particular, persons with psychosocial disabilities, people living in institutions. We've seen quite a lot of people with disability actually move from institution to psychiatric hospitals without being able to see their family, for instance, people being stuck at home, women with disability more likely to face violence, also not having access to mental health care services. And also young people with disability have been particularly affected. So we conducted a survey and 68% of the respondents indicated that the pandemic had a high impact on their mental health. Thanks to the work of our member organization, we also saw quite a lot of good practices and promising practices to support access of mental health for persons with disabilities. So a few speakers mentioned already the positive impact of peer support network and peer support training, which is really important. We've also seen a government increasing funding for mental health. So for instance, in Denmark, the government provided 3 million euro of funding for Danish Organization of Persons with Disabilities in order to fight loneliness and mental health consequences of the lockdown. So it's really important for mental health services to be accessible by persons with disabilities, for instance, deaf person, deafblind person, as general services might not be accessible to them. And also a member, especially Mental Health Europe, for instance, have created a map of helpline and services to support mental health during the crisis. So now very briefly on our recommendation, we need to make sure that policies—
Very briefly.
Yes, just so it's 2 points. It's really to focus on involvement of persons with disabilities and on funding, make sure that services are accessible, and really also to fight coercion, following up on Stephen mentioned to the draft additional protocol to the Oviedo Convention, making sure that coercion is actually not considered as a mental health care. Thank you.
Thank you very much, and sorry for nudging you along. I could make a recommendation to all the following speakers. You should begin with your recommendations because those are the most important points. Next speaker is Ekaterina Skilatse. She is a Deputy Public Defender in Georgia and chair of the working group of CRPD. Thank you, Ekaterina.
Dear colleagues, it is a great honor for me to speak at this very important event on behalf of the Georgian National Human Rights Institution and the CRPD working group on the impact of COVID-19 on the right to mental health. Let me begin by underlining that after more than a year since the outbreak of the COVID-19 pandemic, it is clear that pandemic has caused an immense psychological burden on the population all around the globe. And Georgia has been no exception in this regard. Where quality mental health services based on the human rights approach remain a major challenge for the state, even without pandemic. The government of Georgia has approved the guidelines on the management of patients receiving psychiatric services for their safe treatment during COVID-19. This was a step forward in terms of protecting persons receiving mental health services. However, its implementation in practice has been a problem. At the European level, ENRI as a hub of NHRIs in the region collected information about different challenges and best practices from European countries have experienced during the COVID-19 pandemic, including mental health issues. And we have organized 2 important webinars on these issues. And I would like to underline that we also prepare quarterly newsletters about the work of our members, which also focus on practical aspects and steps taken by the European countries. Based on Georgian experience, along with the work of other members of the CRPD working group, let me share with you today some observations and recommendations which we have elaborated during this period. Establishment of free psychological hotlines is the most common practice aimed at reducing psychological burden resulted from the pandemic. This, of course, cannot be considered as a sufficient mechanism for preventing mental health problems or providing adequate help, but still it is very important to have in many countries. Last but not least, the spread of coronavirus is in closed and residential facilities has revealed that the institutionalization and independent living along the most effective protection from the COVID-19. And the institutionalization process is not easy, especially during the pandemic, but the pandemic, because of its grave result, must only accelerate the process instead of hindering or delaying it. Therefore, I firmly believe that NHRIs can play a crucial role in the process of advocating for effective measures on reducing the impact of COVID-19. Thank you very much for your attention.
Thank you so much. And I would like to bring in out of turn Ms. Manal Azi, who's a occupational safety and health specialist at ILO. And the only reason she is jumping turns is because she has to leave in a few minutes. Manal?
Thank you so much. Thanks, Philip. I'll take this opportunity to quickly bring back some of the ideas regarding mental health in the world of work. And so the focus on the role of employers, workers, and governments in ensuring psychosocial risk management in the workplace is strongly one of our biggest messages today, that occupational safety and health, and for the millions of workers who have kept their jobs or haven't, or have changed work arrangements, working from home or elsewhere, are facing a lot of work-life balance issues and other. Two main things the ILO is doing currently, and you know, the support that we are getting from Europe and other countries globally is important on making the right to health at work a fundamental principle and right at work, which it isn't yet, but you know, from our governing body, this is an ongoing discussion. And health at work, of course, includes mental health. The second is the ILO Convention for the protection of people from violence and harassment at work. We've seen through the pandemic, especially healthcare workers and service providers have faced a lot of violence and harassment. So this convention is a new one relatively from the last year, and the ILO is promoting ratification and implementation of the provisions and standards in this convention in national legislation. Third is we've developed guidance on managing psychosocial risks at work in all economic sectors. They're available online. Good indication on how managers and workers need to be protecting and preventing the onset of mental health disorders through proper management issues and other work-life balance, but also resources and support, health promotion in various workplaces, and also providing a decent physical environment for people to work on, because it also affects the stresses that they face. So this is really quickly, sorry, my recommendations. Happy to discuss further the work of the International Labour Organization in this area. Thank you so much for giving me the.
Thank you very much. And may I suggest that anyone, including yourself, Manal, if you would like to share any documents, that you provide the organizers via email, and they can be sent out in future emails. I would like to give the floor to Anya Fortuna, who is from the European Youth Forum. Anya, you have less than 120 seconds.
Hello. On behalf of the European Youth Forum, I would like to thank you for organizing such an important debate. We're the biggest youth platform in the world, gathering more than 100 international youth organizations and national youth councils, and we have been talking about the importance of mental health well before COVID. So when we saw the COVID hit, it was just the last straw. So we have seen structural inequalities and lack of structural measures to improve the mental health of well-being. So the last half a year did not affect young people's mental health just because of COVID, but it was, things were piling up for years and years. And what needs to be done, we have done a lot of research on this, and we're still conducting research. So what it is important is that young people are included in creating different measures in this aspect. One of the things that needs to be done, as already mentioned by the previous speakers, is on the employment markets, on the labor market. A lot of issues there, talking how young people can access employment, what's the situation when they are already in the labor market, then the aspect of the education, access to social protection and others. There's a lot of things that need to be done, and this cannot be done through a quick fix. So just opening a call line when people can call, it's not a solution. We have to dig deeper, and we have to have broader and more structural changes if we want to solve this situation. The opportunities that we have are now lacking because the issue has really affected a lot of young people. More than half of the people that we conducted research with are suffering with mental health issues, and things need to be solved as soon as possible.
Thank you very much, Anya. And now I'd like to give the floor to a colleague from the Human Rights Committee, Hélène Tigrouja. Hélène, tu as le micro.
Thank you, Philippe. And very briefly, because I have more to learn than to recommend. Now, I would like just to follow up on what Christine from the Committee on Economic Social Rights said about the division and between civil and political rights on the one side and economic, social, and cultural rights on the other side. So I realize, listening to your presentation, that mental health is really an underdeveloped topic of the Human Rights Committee, of course, because the right to health is not protected by the ICCPR. And in general, when we consider health issue, we only consider physical health issues. So it's included in the right to integrity, but we do not work a lot. I have to confess, we do not work a lot on mental health. So my recommendation is really a call, I would say, and I know some of you, Marine and Stephen, it's a call to the civil society, to colleagues from other treaty bodies to raise the awareness of the Human Rights Committee to this mental health issue, as some NGOs did when we had the dialogue with Finland. We included in the dialogue the draft Oviedo Protocol Stephen just mentioned. So it's only my contribution to say that for the Human Rights Committee, it's an underdeveloped topic, and I would really call for more input from you colleagues and from the civil society. Thank you very much.
Much appreciated, Hélène, for keeping time and for your compliment. I would like to give the floor to Chanan Russell, who is from ILGA Europe, which advocates for the rights of LGBT persons. You have the floor.
Yes, hello, thank you very much. As was said, my name is Keenan Russell. I'm a Senior Policy Officer at ILGA Europe, and our main point today that I want to raise is that mental health does not and cannot exist in a vacuum. Structural factors such as discrimination, violence, domestic abuse, hate speech have a real impact on mental health and must also be eliminated to move towards effective mental health protections in the region. For LGBTI people, COVID-19 has heightened the risk of structural exclusion. To build back better, we must eliminate structural and systemic exclusion to create a society based on equality and close the gaps in mental health disparities. In the 2019 FRA LGBTI2 survey, it was found that 30% of LGBTI people in general reported being downhearted or depressed more than half of the time. This number jumped to 42% of intersex people and 44% of trans people. And what is striking is how clearly this exposure to mental health disparities correlates with exposure to discrimination, violence, and stigma on a structural level. So it is vital that responses at national, regional, and international levels to mental health disparities look at the structural causes and the systemic exposure to exclusion and marginalization that is frequently at the root of these disparities. Thank you very much.
Thank you very much. And yes, your points are very important. And many of us are aware of how the LGBT community is really affected in addition to what it endures in so-called normal times. I would like to give the floor to Roger Webb, who's a professor of mental health epidemiology at the University of Manchester. Roger?
Thank you very much, Philip. I'd like to make two points, if I may. So firstly, we see lots of consistent evidence that the mental health impact of the pandemic has been particularly harmful to children and young people, women, people who are deprived. But we should also perhaps consider, large groups of people who don't fit into those categories. So, for example, we shouldn't assume that all middle-aged men are doing fine at the moment, because it's likely that many middle-aged men won't be doing fine psychologically. and we're aware that many people in that demographic, many men, particularly middle-aged ones, that don't engage well with mental health services and primary care services, for example. And we also know that they have the highest suicide rate in the population, certainly in the UK, and I think in lots of other countries as well. So we need to make sure that when we're developing mental health strategies to deal with the impact of the pandemic, that we look at all groups in the population, as well as those that the data are showing to be particularly vulnerable. And we also should look at a wider group of measures of mental health impact as well. So alcohol misuse, for example. Many individuals may be self-medicating with alcohol during the pandemic period, and we need to make sure that we include such measures as well as traditional mental health diagnoses. Second point I'd like to make is about suicide risk. So the evidence we have to date is that although there's been a lot of talk about suicide risk during the pandemic, there's very little evidence of an increase in risk in most populations that have investigated this topic around the world. There's a few examples, such as Japan, where there has been an increase in suicide, particularly in women and young people, but most countries we haven't seen an increase in risk. But the data only really pertain to the period up to the autumn of 2020, and we have very little evidence at all through the winter of 2020, 2021. So in many ways, the winter lockdown was a lot tougher than the summer lockdown, and we can't really feel reassured about the impact on suicide risk until we've seen what's happened through this very tough winter that everybody has experienced. So again, I would call for continued monitoring of suicide risk in the population. Thank you.
Thank you very much. We need more data, of course. Let me pass the floor to Marina Langfeld, who is from the UN subcommittee on the prevention of torture. Marina, please.
Thank you very much, Philip. Can you hear me?
We can hear you. We can
okay, thank you. Well, in 2020, the SPT was not able to visit any places of deprivation of liberty due to the pandemic. For this reason, the SPT issued its first advice to states, parties, and national preventive mechanisms, MPMs, relating to the COVID-19 pandemic. At the moment, the SPT is finalizing a follow-up to its first advice. Partly, it will be based on the information we received from state parties and MPMs on their measures taken to implement our recommendation and on their new ways to deal with the pandemic. For example, reducing the population of places of deprivation of liberty, paying greater attention to hygiene, intensifying care for persons with health risks, introducing new means of communication. Let me give two examples of good practice. First, remote psychological support for detainees and their families. Second, monitoring of social care homes for the elderly. On the opposite, one of the examples raising our concern, the discontinuation of therapeutic programs in places of deprivation of liberty. Further measures the SPT is going to propose will be, among others, first, ensure that all persons deprived of liberty whose mental health is affected by COVID-19 measures receive adequate counseling and psychosocial support. Second, resume in-person monitoring of all places of deprivation of liberty. And third, enhance the cooperation with other national preventive mechanisms and regional networks. That's what we are doing at the moment, and I'm happy about it. And the follow-up advice will be available very soon on the website of the SPT, and I would highly recommend and be very pleased if you would take note of it. Thank you very much.
Marina, thank you very much. Martin Rogan from Mental Health Ireland, if I'm not mistaken. Martin?
Good morning, Philip, and thank you for the invitation. I think it has to be said in terms of, as an island nation, Ireland took a very dramatic response to COVID and very quickly moved to quite significant lockdowns. And this was quite successful as a broader public health measure, but had very significant impacts indeed in terms of constrained access to primary care-based mental health services and community-based services. And this has been an unfortunate trend. There's been a retraction of community services back into acute-based care. There was also some retraction, I suppose, of some of the protections included in our mental health legislation for individuals who are detained. And these were very pragmatic about making sure people were moving in and out of units and perhaps bringing infection. But it meant that tribunals took place remotely, meant that second opinions, the format there was changed. And probably the most corrosive and damaging from an impression perspective, particularly for young people, was that visits were suspended. Perhaps the most graphic image I will have of the last 12 months is in a CAMS unit, a child adolescent unit, where young people were using a telephone to call their parents and trying to peel the frosting plastic off a window so they could actually see their parents while having a visit through glass. So I think that's been quite corrosive indeed as well. I think it's been mentioned there as well, the fact that regulators and independent monitors didn't actually visit units. And that meant that the service quality could become impaired, and it was quite traumatic for service users and indeed for staff members. In my own organization, I think a number of speakers here have already mentioned in terms of the important role of peers and people with lived experience, we actually recruited 60 new staff as peer educators, and they've had a profound role working largely remotely using Zoom and other technologies as well. I suppose in the absence of being able to meet in person with strong social distancing measures as well, the use of technology, and a lot of people became seduced believing that everything could become digital. And this was hugely beneficial for lots of people, but was impossible for people who either didn't have devices, weren't comfortable with the technology, or didn't have a private space in which to use the technology. So major progress has been made in terms of adopting technology, but unfortunately in the last week, the entire Irish healthcare system has collapsed under a ransomware demand as of last Thursday. So there's absolutely no technology available. Simple email, PCs, etc., have all been disabled. So the ground that was made up there has been lost. So there's a fragility in that space that we need to be mindful as well. And one final point is just to mention the whole area of intergenerational cohesion. I must say extraordinary sacrifice was made by young people and young adults in terms of their education, employment, and relationships, without necessarily being the immediate benefactors of this. And we now need to see a rebalancing of intergenerational cohesion in terms of access to housing, employment, opportunities, and pensions, which we don't necessarily see across generations. But I think it's been an extraordinary time, a lot of learning, and perhaps a dress rehearsal for future crises, maybe in relation to climate.
Thank you very much. Bianca Buitavanainen from the European Court of Human Rights.
Yes, thank you. I would like to make a few points concerning the European Court of Human Rights case law on mental disability rights, as we do not yet have cases concerning the COVID pandemic in this field. As you know, the proceedings before the court take time. However, what I want to say is that the work of the Council of Europe, the other international bodies in the field of mental disability, are always of use for the court when the court examines cases concerning mental illness. The court, as you know, does not work in a vacuum. So although its primary function is to interpret and apply the convention, our Convention on European Convention on Human Rights, the court draws inspiration from other international materials, notably the work of the UN, the WHO, and also missions by the civil society, who sometimes participate with third-party intervention in individual cases. And this is particularly the case in the area of mental disability. Our court emphasized the general principles of autonomy, dignity, and participation for mentally ill. This was, for instance, the case when the court decided cases concerning the confinement of mentally ill who had committed acts prohibited by the criminal law.
Sorry, Bianca. Sorry, Bianca.
Yes?
The sound is coming in and out, and the interpreter.
Okay, I'll come closer.
Thank you so much.
Yeah.
And please come to the conclusion. I'm sorry.
Yeah, okay. So I also wanted to mention that in the context of the right to vote for people with mental disabilities, the court said for the first time and in very clear words that the mentally ill are a particularly vulnerable group in the society who were subject to prejudice and stereotyping with long-lasting effects. And this is a principle that now guides the case law of our court. And it was applied, for instance, recently when a mentally ill father, because of his illness, was not allowed contact with his child. When it assessed the discrimination claim, our court expressly relied in its reasoning on the work of the UN bodies and found in favor of the applicant. I will stop here. Thank you.
Yes, I'm sorry, Bianca. Important information from the European Court. I'd like to give the floor to Andrej Martin Vukovac, who's from the Permanent Mission of Slovenia to the United Nations.
Yeah, thank you very much for the floor and for the opportunity to spend this morning in such eminent company and learning so much. I would just like to share a few things that Slovenia made in order to tackle mental health issues during COVID. And the first one was really based in a national mental health program that was adopted 3 years ago. And that one really sets the base and envisages integrated action of different actors on prevention, treatment, psychosocial rehabilitation, and support. And it's centered at the primary care level in the community, so in the community health centers. And even though this, let's say, a national mental plan or program was disrupted by COVID, it still allowed for good tailoring or reaction to the pandemic. And they have quickly adapted in times of the pandemic and responded very proactively to the needs of the community. And that was also possible because there was a very strong network of public institutions, non-governmental organizations, and individual professionals that was established to act in a coordinated manner and coordinated by the National Institute of Public Health. So more specifically, what they provided was support for persons in quarantine or self-isolation. They trained lay people in critical infrastructure to implement psychological first aid. And they provided also individual psychosocial advice to individuals, couples, and families in vulnerable situations. And it really must be said that the richness and the diversity of this network, particularly the partnering non-governmental organizations, enabled us very significant outreach and tailored approach to different vulnerable groups. Nevertheless, mental health impacts of COVID are a challenge that Slovenia will continue to address also during the presidency of the EU Council. And we'll continue to try to find innovative and sustainable solutions in the future. Thank you very much.
Yeah, much appreciated to have some insight on your priorities for the presidency. We would like to give the floor to Beck Smith, who's from the Wellcome Trust. And Beck, if you're available, please take the floor.
Thank you so much, and thank you so much for the opportunity to speak at this important event. At Wellcome, our vision is a world where no one is held back by mental health problems. While the mental health crisis certainly predated COVID-19, COVID-19 has certainly pulled it into the spotlight. Today, 1 in 4 people will experience a mental health problem in any given year. And while some treatments work for some people some of the time, we urgently need to find better approaches that can help more people globally. In response to COVID-19, we funded research to understand its impact on mental health. One such project, COVID Minds, comprises 150 longitudinal studies around the world. And these studies have shown, as many others have said this morning, that certain people have been more vulnerable to psychological consequences of lockdown and social isolation than others. And I encourage you all to visit their website at covidminds.org to find out more. Over the next 30 years, Wellcome is focused on finding the next generation of treatments and approaches to help and treat mental ill health. We are currently funding research that aims to understand the active ingredients, the what works for who, how, and why behind different treatments and approaches. And these approaches recognize importantly that mental health is bigger, and so they span gut microbiome function to better urban access to green space, and from use of antidepressants to increased financial resources via cash transfers. Just as science has been the exit strategy for the pandemic, mental health science must be an important part of the exit strategy for the mental health crisis. We need to see increased investment in mental health science that really centers those with lived experience alongside the crucial existing efforts to reduce stigma and increase access to services. Thank you very much for your time.
Thank you very much, Beck, for that. And I will give 15 seconds to Guadalupe, who would come back as a panelist.
Yeah.
You have 50 seconds before we close.
Okay. I just wanted to say some positive examples and initiatives that are taking place. And one of them is the excellent initiative of WHO on quality rights, in which we have been very much involved. Also relating the Oviedo Convention, a European network of ex-users and survivors of psychiatry, which I'm its deputy chair. We have been very much involved in it in a meaningful way with the European Disability Forum. The UN and WHO organized an amazing global event online last Mental Health Day. And there has been a huge campaign called Break the Chains of Human Rights Watch and WHO. So that's all. There are positive things going on.
Thank you so much, Guadalupe. Unfortunately, it's time to wind down this very stimulating webinar. I've never tried speed dating, but my idea is that it's probably not as bad as this type of really rapid fire, because there's so many interesting ideas. For closing, I'd like to give the floor to Birgit van Hout to share some closing remarks. Birgit heads the UN Human Rights Regional Office for Europe in Brussels. She holds specializations in law, international politics, and international human rights law. So in a way, she is predestined to tie neatly together all we have heard this morning. Thanks for closing this webinar. And before I give you the floor, may I simply thank the team that expertly organized the webinar and for the honor of serving as moderator. And thank you for the interpreters that I have admired all along. Thank you very much, Birgit.
And thank you, Mr. Jaffe, for this excellent moderation. And it is true, there is so much information that we try to squeeze into an hour and a half that unfortunately we're not able to do justice to all the perspectives, I find, as we would have liked. But nevertheless, I thank everybody who participated. And I also like to thank the teams both from Geneva and from Brussels here who worked together very well to organize this. I was asked to sort of wrap up and provide an overview in a nutshell of the main thoughts and ideas that were shared during this webinar. And I think I would not dwell on the impact of the pandemic on mental health. I think many of you gave illustrations of how the pandemic impacted mental health, and this is something that at this point can no longer be contested, right? The second very strong thought that came out is that mental health is about human rights, and that a service denied is a right denied, and that we're talking here about legal obligations, meaning we're talking about right holders and duty bearers, and the persons are still persons with psychosocial disabilities or persons with mental health challenges are still too often seen only as objects of care. Talking about legal obligations, we have, of course, the European Social Charter, we have the ILO conventions, but clearly we see that there is an implementation gap. And this is, as we heard, not only always a question of funds, although funding does play a role, but also of human resources. And as we really need a long-term planning and strategy to put the right responses for building back or recovering better in place. And it was also highlighted in this context that one of the reasons why the thinking around mental health from a rights-based approach has not been so developed is because over time or traditionally civil and political rights have tended to enjoy more attention than economic and social rights. On then I'd say the third element that came out quite strongly is how COVID-19 exacerbated or exploited, I would say, or worsened already existing vulnerabilities. And personally, I should say, I don't really like the term vulnerable groups because I think nobody is born vulnerable, right? We're made vulnerable under certain circumstances. So But it is clear that certain groups that are defined already under the various conventions and treaties, like women, have suffered particularly, but also this COVID-19 has made new vulnerable groups, if I may say so, or has highlighted that new groups have been impacted by the pandemic in a particular way, and that we need to really conduct a mapping of this, and this also requires the collection, of course, of disaggregated data. And we're thinking the persons that groups of people that were mentioned frequently were young people, older persons, healthcare workers, etc. Now we heard about a number of good practices. We heard about the pilot project on digital psychotherapy. We heard a lot of good things about peer support networks. We also heard that there has been an increase in mental health spending. And we've heard also about quite innovative initiatives like psychological hotlines, etc. And then I would maybe say that the main gist of the discussion, though, was that what really is required is a paradigm shift, a holistic and rights-based approach that focuses on participation, transparency, and accountability. Many of you made clear that mental health does not exist in a vacuum, and mental health challenges, they're part of often structural inequality, structural violence and exclusion, and that therefore mitigating social economic inequalities can also mitigate inequalities in health. So a few of the recommendations that were given in terms of a rights-based approach to mental health would be to bring the mental health laws at national level in compliance with international human rights law and with the rights-based approach. But also to continue and maybe intensify the human rights monitoring in social care homes and institutions, which some NHRIs, but also civil society and CPT and SPT are also doing. A lot of agreement around the holistic approach, so meaning that the right to health is also connected to our other economic and social rights, social protection, right to housing, etc., and that we need more broader and more structural changes that move away from the victim-oriented approach to the rights-based approach. We all also agreed around the principle of participation and its importance, and as reflected also at individual level, the need for decision-making and consent of the right holder. In terms of structural changes, we clearly heard the echo of the need to progress more and faster towards deinstitutionalization to prevent EU funding from going to institutions and to address coercion, but also to move away from an over-reliance from on a medical approach to mental health, and better mental health science. And I think last but not least, and maybe I can close on that note, the importance of cooperation across the different bodies, across the different levels of competence, and in an interdisciplinary manner, as has been illustrated in this very rich discussion. So cooperation also with civil society, with national human rights institutions. We need everybody in order to come up with the best way forward to address the impact of the pandemic on mental health. So rest to thank you all for your very active participation. I feel like we could have continued the discussion much longer. Apologies also if I wasn't able to capture every single element that was said, but there will also be a report of this meeting. And wishing you all from my side a wonderful day and rest of the week. Thank you.